Yes. Right. So we are almost ready to begin now. It's a very short, what is called as short-term planning. Of course, Ritu ma'am, as usual, suggested the topic. She said IT band. I had announced this as a topic for Masterclass for, I think it was Nepal or Bangladesh, but I didn't take it on that same topic. And I changed the topic to sciatica and then I took it because people were not much interested to see IT band as a separate topic. Today, when I was registering everybody, even Dr. Nitin Kumar, our core committee member, he also asked about, are you going to take a special clinical masterclass on ITB? Okay. Because he saw this flyer and I have put these points in the right side that the contents of this today's webinar. So these are all things we can discuss. Why I have put that is because people will get some clue to ask questions. Okay. Otherwise, people don't know what to ask and what not to ask. Okay. So either way, I have shared the questions in the WhatsApp group so that everybody can see what others have questioned. So in every level, it will be like a exchange of thoughts when you see the group itself. Most importantly, before we go into the group, I have pleasure to introduce two people who's sitting to my left. It is Ritu ma'am and also Darshana. So both of them are what is called as, if they both are there, I don't need any other participant at all. Okay. So that is the reality of the dedication and the passion that they both have in learning, and which even I cannot even dream of competing, okay, with them as a learner. Okay. So it's amazing that they have done the triple fellowship of the AOMPT. They have done the ortho, sports and the neuro fellowships. It literally means that they have not missed any courses and they have all the videos after me. Okay. If I am creating something new today, it will be there with me. But the moment I share it to them, they also have equally the same videos what I have. So the full AOMPT is there with them. And they are also fully for the AOMPT all these times of this lockdown and what we had adventure in transforming ourselves through online learning. AOMPT is, you always know that there will be a lot of difference. I hope that the participants today are attending with an expectation that we never thought about all these points which were mentioned in the flyer. The ITB or a tensor fascial Latae syndrome. So you've seen these points, then you realize that, oh, there are so much about ITB. Okay. And we are seeing this ITB dysfunctions in hip problems. We are seeing this ITB dysfunctions in knee problems. We are seeing this ITB dysfunctions as more of what is called as a post-operative THR, okay, after a hip replacements. So these all are more common. And sports injuries, of course, the term itself, runner's knee. So it means that it is the iliotibial band tendinitis. Okay. Remember that one thing that I will just start with asking some questions which you can reply on the chat. Most importantly, I want to ask you, like, how many of you feel that tensor fascial Latae and IT band, okay, both are same? Either they are same or different. Tensor fascial Latae and IT band. Before that, I will enable unmute of one of the participants, Dr. Anup sir. He can unmute now. Okay. So that he can ask me the question directly on the screen. Anup sir. Okay, he's traveling. Let him reach. After that, he can ask the question. Otherwise, we'll feel like we are all sitting in a big bus and we are all traveling together. Okay. How many of you replied? Dr. Karupusamy, myself. You want to ask question? I am asking you a question which I want you all to answer in the chat. I asked you whether tensor fascia lata and iliotibial band are same or different. One question from Muzamil, one answer from Muzamil is different. Dr. Karupusamy same. Kazm is telling different. Renuka same. Anup sir same. Remember one thing. People who are telling it is same, they are anatomically same. Okay. People who are telling they are different, they are biomechanically different. Okay. So anatomically same means they are actually a single structure. Okay. So it is actually a single structure like the ligamentum petae and the quadriceps. So although that ligamentum petae can be called as a patellar tendon, okay, and the quadriceps is a muscle, so this is tendon. Same way tensor fascia lata and iliotibial band actually are continuous. Okay, so it is embryologically, of course, the iliotibial band is first formed because it's a fascia which always forms first. After that, the muscle is formed, the tensor fascia lata. And when you are hearing this term tensor fascia lata, how many of you know where is the fascia lata? You can raise your hands. So anatomically it is single structure. Biomechanically it's different because the properties are different. One is muscle, the other one is fascia. So their properties are totally different. Of course, one is contractile, another is non-contractile partially, or it can be indirectly contractile. Okay, so that is the iliotibial band. It cannot directly contract independently. Okay. So how exactly? Kazam Mana has mentioned that, remember, fascia lata is the fascia of the thigh. So that is everywhere. Full thigh, anterior, medial, lateral, posterior, the compartments that are formed for the thigh muscles, everything is formed by the fascia lata. So do not think that the fascia lata is the ITB alone and tensor fascia lata is attached to that ITB. Okay, so do not have that misunderstanding. And another thing which you should note is this fascia lata in the thigh, it's like a stocking. You remember the word stocking? Okay, we wear it like a socks in the thigh. The tensor fascia lata is, it pulls the stocking up. Okay, so we have in the stockings also in the Western, you will see in the movies that they wear the stockings with the straps, and that straps, because the stocking should not get removed, that strap is similar to the tensor fascia lata. So that is holding the stocking there up. So if that strap is not holding, the fascia lata is going to collapse towards the foot. Okay, so it is going to gravitationally collapse. Bulky muscles, large structures in the thigh. So because of which the fascia is always loaded. Okay, and there will be collection of fluid, everything. So if you have the tensor fascia lata, it pulls that stocking up and maintains the anatomical integrity, okay, of the thigh fascia, that is the fascia lata. So remember that it is there everywhere. The fascia lata is there everywhere. It is the deep fascia covering each and every muscle of the hip. It's nothing but the fascia lata. And of course, internally separated by intramuscular septa. I think you would have seen it in Google. In online, it's very easy. Parallelly, you can just open a window of Google and then you can type. Also remember that it's very valuable for self-learning to just refer to Google and you can learn a lot of information. So what we have here is, next is, we have seen what is contractile, what is not non-contractile between these two. If you want to actually locate what is called as the iliotibial band or the tensor fascia lata. Where do we locate? That is the name itself, iliotibial. Okay, so that is from the ilium to the tibia, and it is present laterally in the thigh. And tensor fascia lata is anterior to that iliotibial band. Gluteus maximus is posterior to the iliotibial band. So it is a kind of a tree branch. Okay, the trunk is there. Anterior branch is tensor fascia lata, posterior branch is gluteus maximus. Okay, both are attached to the iliotibial band. So remember that the iliotibial band is not just from the greater trochanter to the tibial tubercle. Tibia also, the lateral part of the tibia, okay, is called as the above the fibula. Okay, so fibula is there, and above that, okay, so this is the lateral side. Okay, this is the tibial tubercle. Okay, tibial tubercle here, and here fibula is there. So that is the lateral side. So this tubercle here is called as the Gardy's tubercle. It's also sometimes pronounced as Gerdy, G-E-R-D-Y. Okay, Gardy's tubercle. That is the place where the final distal attachment of iliotibial band is. And in the femur, it's indirectly attached. Okay, that means there is no direct bony attachment except through the fascia, like for the muscles, covering the muscles and then attaching through the muscles on the femur. So it does not have a direct attachment. Okay, iliotibial band. But the fibrous expansion here at the greater trochanter, okay, here at the greater trochanter, has a close attachment to the periosteum of the greater trochanter. So because of that reason, iliotibial band can be distinguishable like from greater trochanter to the Gerdy's tubercle, okay, as more as a non-contractile tissue. And it is influenced by hip movements whenever the trochanter is moving. And you know that if you rotate the hip medially and laterally, trochanter is moving anterior and posterior. If I am keeping, this is my left femur, I am doing an internal rotation. That means trochanter is coming anterior. Okay, so there's a shift in that iliotibial band that comes with the internal rotation of the hip. So there were people who were asking about how the hip can influence the knee through the iliotibial band especially. And also this is what it can influence. So internal or external rotation of the hip can influence directly because the attachment on the greater trochanter, the iliotibial band. And another thing is the tensor fascia lata is above the trochanter, which is iliac crest. So you have the iliac crest and you have the femur. Okay, so this is the Asis. So from the Asis, okay, from the Asis to the iliotibial band. The iliotibial band greater trochanter is here. Asis is here. So between that, anteriorly, that is tensor fascia lata. Small area. Okay, what you have is only a kind of maybe less than 3 inches. Okay, so that is the distance from the Asis to greater trochanter. So if you are having tenderness at the Asis, and then when you are having tenderness till the greater trochanter, it means that it is tensor fascia lata tenderness. Okay, so and anterior part of the thigh, anterolateral part of the thigh. Okay, so that is tensor fascia lata, because if I keep the pelvis here like this, okay, this is the anterior view. So this is Asis, and here is the tensor fascia lata. Okay, and here is the trochanter. So afterwards, if the tenderness is present from the greater trochanter and distally down, okay, distally down all the way till the Gerdy's tubercle, okay, I can be clear that it is the iliotibial band tenderness. So that is about the palpation, anatomical landmark, the surface anatomy and the palpation. So the next thing what I would want to tell is any structure goes for a dysfunction in the human body. What reason they go for a dysfunction? People were asking about the causes of why an Itb syndrome should come. Remember, syndrome means everything that is related to the structure. That means anything can happen to the structure, it is a syndrome. If I tell that Itb syndrome, it means that whatever I am going to mention now. Itb trigger points, Itb rupture or partial tear, Itb tendinitis, tendinosis, tenovaginitis, Itb bursitis, okay, and also Itb adhesions, okay, that is their scar or adhesions, and IT band contractures due to a connective tissue disorder. Everything will include that IT band syndrome. What is the definition of an IT band syndrome? Is pain arising from an IT band due to its dysfunction. The dysfunction can be any range. It can be any of the dysfunctions which I mentioned a while before. So understand that every soft tissue structure in the human body has the same tendency to get dysfunctional in all these aspects. If you see for triceps, triceps has the tendon, triceps has the bursa, triceps has the belly. You always have the same problems of triceps rupture, triceps tendinitis, polycranon bursitis. All these are there everywhere. So you can name the same for triceps syndrome. It means that every dysfunction of the triceps. If I tell, for example, pectoralis minor syndrome, that means every dysfunction of the pectoralis minor. So remember that Itb syndrome is not actually a clear specific diagnosis. It is a big broader term of all conditions that is affecting the Itb. And in that syndromes, primary and secondary are there. Primary means problem of Itb leading to pain from the Itb. Secondary means problem of some other muscles, some other structures leading to symptoms in the Itb. So secondary and primary both are common everywhere. It is like the myofascial pain syndromes. So you can have primary myofascial pain syndrome, that is the muscle's own problem leading to its own pain. I have tight upper trapezius and the upper trapezius becomes painful. That is the only problem in me. Then it is a primary myofascial pain syndrome. But never in the human body it will be primary. Always it will be involving multiple structures. So when you are approaching the Itb, do not assess only the Itb. It means that you have to see what has caused the abnormal loading of the Itb. Whenever I mention Itb, it also means the TFL, the tensor fascial lata. So remember that what is that abnormal mechanics which has caused the abnormal loading of the TFL? That is important for us. What is called as the pathomechanics. You cannot just go by thinking like tensor fascial lata trigger points versus Itb trigger points. Both are there. Maybe, remember one more thing. Itb is like I told that it is like a fascia. It's like a sheet-like structure. It cannot shorten and lengthen itself. But its attachment to the other muscles of the thigh makes it to move whenever the muscles are working. So thigh muscles are working means iliotibial band will be moving. Even for rectus femoris, when it is working, Itb will move. So remember that because it is like that stocking. Whoever pulls the stocking from anterior or from posterior or from lateral, stocking is going to go up. That is the fascia lata. The fascia lata is thickened fibrous laterally. That is iliotibial band. Okay. So always remember that it can be indirectly moving with response to other muscles contraction, the adjacent muscles which are there. So do not think that iliotibial band cannot contract, can indirectly, okay, be influenced by the other muscles which are adjacent. Which are the adjacent muscles which can influence the ITB below the greater trochanter? Because above the greater trochanter, we have seen that it is when you have the femur and you have the innominate bone, okay, that means anteriorly tensor fascia lata and posteriorly gluteus maximus. So this both are there. That is above the trochanter. Below the trochanter, what is there? Anteriorly the rectus femoris and posteriorly the biceps femoris, the lateral hamstrings. Okay, so that is the fascial connection there. So please remember this muscular connections, because if you are treating ITB, you should definitely evaluate these muscles. Because if the anterior group muscles like tensor fascia lata and rectus femoris, they are tight, ITB gets shifted anteriorly. Posterior group like gluteus maximus can be weak. So that will aggravate the situation that the ITB will come more anterior, because anterior muscles are tight, they are shortened. So tensor fascial tightness, tensor fascial lata tightness or rectus femoris tightness definitely will pull the ITB anterior. The moment anteriorly ITB comes, everything changes. Also remember that in the knee also the ITB is having paradoxical action. Paradoxical action means if you are keeping the femur and the tibia, okay, so you're keeping the femur and the tibia, laterally the head of fibula is there. Okay, this is the fibula. Okay, so from here the guardius tubercle here. So from the guardius tubercle and then along the femur the ITB goes laterally. So 20-degree flexion, when the knee is flexed, ITB will become posterior to the knee joint. So knee is flexing, okay. For example, I keep it like this, okay. Right? Yeah. And then I have the flexion. When it flexes, the ITB becomes posterior to the knee joint. So ITB will produce flexion of the knee. If the flexion is not much, it's only like 20 degrees, less than 20 degrees, then ITB becomes anterior to the knee joint. Because of that, ITB will produce the extension of the knee. So it is like our politicians who are there in India. Whoever is the winning side, they will go and have the alliance. So knee is already flexing means, knee is already flexing beyond 20 degrees, ITB will become a flexor. Knee is less than 20 degree flexed, ITB will be staying as an extensor. So that is the paradoxical action there. One thing in ITB. So we need to evaluate the ITB in both the positions. That is with the extended position also, with the flexed position also. Even for strength and also for length. That is why the Ober's test is done as modified Ober's. In the Ober's test, we keep the knee extended, whereas in the modified Ober's test, we keep the knee flexed. So remember that special test name alone, remembering it is not at all useful. What is the component of the test? So in that, why are we modifying it? Okay. And another thing which I want to add before we go to the questions is, this is the iliotibial band. Okay. And this theraband that is in orange color, and you know orange or saffron is the most powerful. Okay. You're not supposed to use any other color in India. Okay. So imagine that these two are connected. Okay. So what is the white one? ITB. What is the orange one? It is the tensor fascia lata. Right? Nobody is talking. Even the two who can unmute also, everyone is silent. Okay. I don't think it's interactive. You know, it becomes like a lecture demonstration like that. So tensor fascia lata, this is elastic. It can contract, it can lengthen, concentric, eccentric, isometric type of contractions. Whereas the iliotibial band just moves with the tensor fascia lata. Okay. And how it will move? Anteriorly it will move whenever tensor fascia lata is contracting. If the gluteus maximus is contracting, okay, so gluteus maximus is contracting, iliotibial band will go posterior. Tensor fascia lata is contracting, iliotibial band will come anterior. Moment iliotibial band comes anterior, it becomes more of an extensor of the knee, because iliotibial band line of action, moment it is anterior, any of the line of gravity moves anterior means it will become extension of the knee. Whereas the iliotibial band moves posterior, it becomes a flexor of the knee. This iliotibial band, if I am keeping on the femur, okay, here femur is there, greater trochanter is there, I keep the iliotibial band. Okay. Even if I do a rotation force, okay, I do a rotation force. This is external rotation of the femur, left femur. Okay. This is internal rotation. Okay. So this you can also see in the lateral view that when I do an external rotation, the ITB goes posterior. Okay. And when I do an internal rotation, ITB comes anterior. Okay. So always remember that ITB can go anterior or posterior depending upon whether tensor fascia lata is overactive or gluteus maximus is overactive. And gluteus maximus rarely goes for overactivity. Okay, it will not go for overactivity. So instead of gluteus maximus, who's the person who helps that gluteus maximus? Is the piriformis. Because piriformis is attached to the greater trochanter. Okay, so trochanteric fossa, so that area. So piriformis is attached. So there is the facial interconnection here. So it can influence the ITB. Okay, so it can rotate the femur because piriformis is also having a paradoxical action. If you remember the action of piriformis on the hip joint, okay, if the hip flexion is neutral or hip is flexed less than 60 degrees, okay, less than 60 degrees, it is an external rotator. Okay, whereas beyond the 60 degrees of hip flexion, piriformis becomes an internal rotator of the hip. So remember that, and this paradox in the hip by the piriformis actually matches the paradox of the ITB in the knee joint. Because ITB flexion means it will create more flexion. Knee flexion is flexion means more flexion. Knee is extended means more extension. Okay, like that. Whatever I am talking is just the pathomechanics. Unfortunately, this pathomechanics is not routinely addressed in our curriculum. People will find difficulty in understanding. And those who are listening first time, you will not understand anything head or tail. Because if your strong fundamental knowledge and foundation not there, or you are not regularly attending to the AOMPT courses, you will find that it is so much, it is interlinked, so much is there, but I don't understand anything. Okay? But that is the reality. You can't help it unless you join the courses. We are actually planning for a clinical certification course on the Itb syndrome. Okay, separately how to treat the ITB and its dysfunctions. So, although I have treated the ITB as part of the total hip replacement, as part of the piriformis syndrome, as part of the patellofemoral pain syndrome, as part of the OA knee, osteoarthritis of the knee, still ITB in itself separately we are going to take as a clinical certification course, which is going to be 2 hours of manual therapy demonstration, including evaluation of not just the ITB. With ITB, which all structures we can examine. Because how to identify that ITB is dysfunctional with joint also dysfunction, ITB dysfunction with other myofascial dysfunctions, ITB dysfunctions with the neural dysfunction. If you are talking about, you would have seen a question in the WhatsApp group. It was put by Ritu ma'am, Ritu Sani, or core committee. Madam had asked about that question about that articular, myofascial and neural. I would request Madam to ask the question again. Yes, ma'am.
Yes, sir. Yes, sir. My question is that patient after the bilateral TKR, the 20 days is over now. The partially stitches are removed because in 2 or 3 stitches there is a pus formation. So doctor has not removed that stitches. But articular, she is not having a pain in a hip joint or in any other area. And I have tested the neural component also. There is no pain in a neural, that lateral femoral nerve or lateral cutaneous nerve, but the myofascial tightness I found it in the IT band, because when she is going to little abducting her legs, she is feeling pain. So there is some tightness. So actually I want to ask this question, that before partially that stitches which are not healed yet, so we have to wait for that removal of that stitches, or they will heal, then we will give the myofascial release to ID band, or we can add something other thing so that the patient can get relief in this position also. Yes, sir.
First of all, it's a post-operative case.
Yes, sir.
Which I have always been highlighting, that no decisions will be taken without discussing with the surgeon.
Yes, sir.
So point blank, whenever it is a suture and then it is healed or not healed, whether it is infected or pus is coming or not, whatever it is, no decision making will be taken by any physical therapist without consulting the surgeon. Okay, that's the point blank, and then follow the surgeon's advice. Point blank.
Yes.
You are not going to do anything extra beyond that, and there is no question at all beyond that. But still, if you want to think, you don't want to do anything on the patient, but you want to understand and you want to think.
Yes, sir.
Then first thing you should think of, you are aware of many myofascial techniques. Every myofascial technique is not going to provoke the symptoms of pain. Every myofascial technique is not going to stretch the iliotibial band. So you know that there are techniques which you can use to relieve the pain and also not to stretch the iliotibial band. There are techniques. So what is that consideration? What is that which you have to be afraid to use those techniques? Because they are not going to aggravate the pain. They are not going to create loading on the suture. So then what is the thing which you have as a doubt? That whether we can use any myofascial techniques. That means you are using myofascial stretch alone. There are myofascial, there are multiple techniques without stretching. Gliding of the fascia is something which you can do anytime. Approximation of the fascia you can do near the scar.
Yes,
everything is all theoretical, but point blank, orthopedic surgeon. This is understanding for the reasoning purpose. What we are discussing is. And another thing which you told, abduction. In abduction, how the IT band will be getting stretched. Adduction only, it will be getting stretched.
Yes, sir.
So think of, it is contracting and it is paining. So muscle is contracting, active abduction patient is doing. That time the pain is coming. It's not the stretch of the ITB, it is the contraction, shortening. ITB, imagine like ITB is a tendon. Okay. And tensor fasciae lata is the muscle. So the muscle with the tendon, it's contracting. So you are getting the pain. That is during active abduction, not passive abduction. Passive abduction, if you are having pain, it should be trochanteric bursitis. You are abducting the femur, okay, passively, and the subject is having pain because trochanteric bursa inflammation, so it is getting compressed. So trochanteric bursitis. And whatever be the case, primary thing is always wound healing. If the wound healing is not proper, you are not going to have any business there. First and anything, unless the surgeon tells, ignore that. go ahead with the functional mobilization, for example, like walking, or maybe the quadricep strengthening, which is close kinematic. Because strength is important, balance is important, proprioception is important. At the same time, the surgeon will be only considered about suture infection should not go to the prosthetic infection, the TKR prosthesis, and create an implant failure and osteomyelitis, which is a major complication. So I don't think any surgeon will ignore the infection. And as a therapist, you also should not even think of ignoring the pus drainage or the infection and then going ahead with the treatment. Patient's comorbidities, maybe to some extent, whatever, it will determine the wound healing. But you have techniques in manual therapy, especially in AOMPT, what we are teaching, where you will not provoke symptom at all. And you can always use the structures far away from the region where it is involved. Yes. And even one side painful, other side which is less painful, give the exercises. Crossover effect of recovery will come in this side TKR, because other side TKR is milder, not much symptomatic.
Yes.
So all this goes hand in hand. And most importantly, which I would want even all the viewers who are sitting here to understand is, come on the screen, everyone. Everybody come on the screen. Aman Varma, Manikandan, Abha Sahu, Gloria, and Renuka. Gloria, Renuka, Abha Sahu. Shrishti Sahu. Ritu ma'am is off the screen. Okay. Renuka, Aman Varma, Abha Sahu. Final call. Others who are regularly attending AOMPT free webinars will know that people don't come on the screen. It's not just about no certificate. I will just remove you out of this meeting. Okay, it's very simple. When I call, you are supposed to come on the screen. Then only attendance. Remember that I am professor of professors. So don't take it so easy that we register and then we get a free certificate. Okay. Where is Aman Varma? I'm not able to see clearly. Okay. So, right. What we have now is to go to the next question. So, who is going to ask the next question? Oh, madam joined on screen. Who's raising the hand first will get the chance. Who's going to ask the question now? I'll enable the unmute. You're supposed to raise your hands. Anup sir is raising the hand during driving. Eh? Other people are not at all having hands. Nobody wants to ask any question on the screen.
Sir, Dr. Muhammad Muzammil is raising hand.
Yeah, enable him to unmute. Where is Muzammil? Yeah. Next is Manikandan.
Yes, sir.
But Muzammil, are you unmuting? Yes. Ask your question. Is it audible, ma'am, Ritu ma'am?
No, sir. I am not able to even.
Not clear. Okay, Muzammil, try after some time. Manikandan, enable Manikandan to unmute.
Even I am not able to see myself. Where is my view?
That's okay. You are able to see me now.
Yes, sir. You are completely visible.
Okay. Where is Manikandan? Unmuted? Anybody else? If Manikandan is not unmuting now, means I will give next to another people.
Yeah, he's raising his hand, but I think not able
He's
to
not
unmute.
unmuting. Okay. I have given the request asking to unmute thrice. Next is who? Sunil. Smart man. In the system, you don't know how to raise your hand in the Zoom.
Hello, good
Yes,
evening,
Dr.
everybody.
Sunil.
Yes, sir. Am I audible, sir?
Yeah.
Sir, good evening to everybody. My question is that how to release tenderness on TKR patients or sciatic conditions on iliotibial band.
Okay. It's because you are asking this question, obviously, because you have not taken the TKR masterclass. Okay.
No, yes, sir.
Point is total knee replacement
Yes,
is
sir.
only a surgical procedure.
Sir.
First of all, you should see what stage of surgery the patient is.
Yes,
immediate post-op, like we are
Right.
talking about a suture healing, okay, in
Right.
the front of the patella. And then in the TKR, whether it is patella retained or patella also, or patelectomy or patella also resurfacing. Okay.
Right, sir.
3 types of TKR are there.
Sir.
And of course, then it comes to the compartments, whether medial or lateral or full tri-compartmental replacements.
Sir.
You don't decide by TKR.
Sir.
You decide by what is the actual problem of the TKR. Whether the patient has quadriceps lag,
sir,
or the patient has a fixed flexion deformity.
Sir.
What is the exact problem? Okay, so then that dysfunction will indicate us to either strengthen the quadriceps during the ITB release.
Sir.
So I'll ask the subject to do the contraction of the quadriceps. At the same time, I'll release the ITB.
Okay, sir.
Okay. If it was a quadriceps weakness which was there after the TKR. Lagging. Okay, quadriceps lag, which usually comes in the TKR. 20 degree like that, it will be lagging. So that time quadriceps activation with release. Simultaneously I'll give. Why I'll give simultaneously? Because if I'm individually strengthening the quadriceps, it will not help the ITB.
Yes, sir.
They both have to function together. So AO and PT always we treat structures together.
Sure.
So it's a problem-oriented approach. So you have a quadriceps weakness, strengthen the quadriceps.
Sure.
When the quadriceps is contracting, at the same time ITB release will be given.
Yes, sir.
And the next one, when you see for if it is like fixed flexion deformity of the knee after a TKR, in that case, what I will do is I will have to improve the extension. Okay, of the knee. For extension of the knee, what you are supposed to do? If this is the femur and the tibia,
yes, sir.
I am supposed to do an anterior glide. Okay, so it's a flexion deformity. Fixed flexion deformity. So to increase extension, what I should do? Give the anterior glide to the tibia. Okay, so that it will create the extension. Okay. I give posterior glide, it will improve the flexion, early staging of mobilization, TKR. If I do an anterior glide, it will come to the extension. So anterior glide, I will maintain the anterior glide of the tibia, and in the side lying position, I will do the ITB release. So that means whatever I do it simultaneous. I might do an anterior glide of the tibia, okay, not manually also. I can use the Mulligan belt. So this Mulligan belt, I can put it around me, and then I can put it around the tibia, and I can easily pull the tibia into anterior glide. So this is tibia here. So I am standing in front of the tibia and I am pulling. So what will happen? The tibia will come with me. Okay. So that anterior glide I can produce either I am putting around my waist or my shoulder as per the height or the position of the subject. And then I can do simultaneously the anterior glide of the tibia with the ITB release together. But most importantly, all these are only temporary options, solutions. Because flexion or extension, extensor lag, quadriceps lag, or fixed flexion deformity, it is only the knee joint which you are thinking. But the knee loading, the stability, the valgus varus, everything is determined by the hip stability. Recent literature clearly demonstrates that in every problem of the knee, be it a patellofemoral pain syndrome or osteoarthritis of the knee, you have to strengthen the gluteus medius and minimus. If you don't strengthen these two muscles, you are not at all rehabilitating a patient of lower extremity problem, any problem. Be it an ankle sprain, be it a plantar heel pain, be it sciatica, whatever you name the condition of the lower limb, if you are not strengthening gluteus medius and minimus, you are not at all treating the patient. Because they are the stabilizers of the hip, and hip only determines how the rest of the lower limb will be, especially in a closed kinematic chain. When the foot is fixed, movement is happening at the knee and the hip during squatting, stair climbing, walking, stance phase, okay, closed kinematic. So these all things. So remember that gluteus medius and minimus activation should be done with the help of, do not think that there is a term gluteal amnesia. So gluteal amnesia is there, gluteal amnesia is there. All those people who are talking about gluteal amnesia, have you ever used this device, which I am having in my hand? The stabilizer pressure biofeedback unit for motor control retraining, which is gluteus medius and minimus re-education in the hip. I want participants to text on the chat that whether you have used this pressure biofeedback for training the gluteus medius and minimus in the chat. Redmi Note 8 Pro. Who's that? Without name and all, I will not enable. Srishti Sahu is used for the hip. Good. For gluteus medius and minimus. Srishti Sahu. Srishti Sahu is on the screen. No idea.
Yes, sir.
Yes, Srishti. Can unmute? Bhumika not used, Neil Shah not used. Srishti fast, unmute. Can't unmute because when I am giving option as to unmute, you are not clicking at the same time. What, Srishti?
Yes, sir.
Yeah, tell me, what position do you use this? How do you train with the pressure biofeedback for gluteus medius and minimus?
In sideline position. In sideline position.
No. Side lying is where will you keep the pressure biofeedback if it is in side lying?
Sir, in supine lying below the back and asking the patient to tilt the pelvis posteriorly.
Posterior tilting of pelvis is for the lumbar muscles. If pelvis is posterior tilting, either it is the anterior trunk abdominal muscles or hamstrings, posterior tilt of the pelvis. Anterior tilt means psoas major or rectus femoris. That is for pelvic tilt.
अच्छा मतलब ना.
So remember that first and foremost, we actually use mostly for the lumbar spine problems, or we have used for the cervical spine problems very rarely. This pressure biofeedback has to be used. There is a separate course in the AOMPT for using the pressure biofeedback. How to use it for quadriceps, how to use it for what is called as gluteus medius and minimus, how to use it for every muscle, soleus also, how to use it for the arch control in the foot, how to use it for the rotator cuff in the shoulder, how to use it for the middle trapezius of the scapula, how to use it for even forearm supinatus pronatus stability training, and also intrinsics, the lumbricals, how to use this. So this is something which you need to explore, and without this, you are not going to rehabilitate the patient at all. Because without a motor control and stability, all your treatments are temporary effect. You might release it, but if the activation is not proper, again it will go for an adhesion. Again it will go for a trigger point. So it's important that motor control retraining has to be part of the rehab, and it has to be progressed to closed kinematic chain, balance and proprioceptive training, because open kinematic chain is not functional. Daily we are not using kicking the leg. Okay, in the football alone we are not kicking. We are walking, we are stair climbing, we are squatting, sit to stand, running. Running may be partially we are off the floor, but all these activities involve weight bearing of the leg. So closed kinematic. So where we need maximum proprioception, the joint compression and the muscle control, co-activation of all the muscles. It's not just the medius and minimus alone. So that is why motor control retraining is important part of any musculoskeletal rehabilitation. Post-traumatic, after a trauma, if there is a fracture, yes, of course, fracture has to be immobilized. Even then, immobilization stage, you can use motor control because it's not a movement. You can use isometric. And the intensity of contraction can be modified by the pressure, how much pressure it changes. Patient can use it with eyes open, eyes closed, recheck how much is the contraction, whether I am doing optimal contraction or not. Once he had learned the contraction, he can use the same amount of contraction in all his functional activities. So if it is gluteus medius and minimus, the co-contraction will be with the transverse abdominis and multifidus and pelvic floor, because the adjacent region has to be co-contraction. This may be useful even in a sacroiliac dysfunction. This may be useful in a sciatica. And coming to the question of Dr. Sunil, when he asked about in sciatica, how will I release an IT band? I will release the IT band in the SLR position, in the side-lying SLR position. Or I will make the patient to bend the neck also in the side-lying, because it will come to a slump test position. And then I'll release the ITB, because primary problem is sciatica, neural. So neural position I should keep and then release the ITB. That is the logic of what we make decisions in AOMPT. Unfortunately, with whatever I am telling, do not try to give treatments. Okay, so that's the major thing here, because treatments are not as easy as you imagine that you can just dream and then you can do it. The techniques of how we administer the treatment, the course, the depth by which the instruction is given, I have demonstrated myself. And the people who participated in the courses know very well. The regularly whoever is taking the videos internationally. So do not even think that I will just keep in the SLR position and then I will do the release. The release techniques, different manner it is there. It is not just a myofascial release. It's a fasciomuscular release. That fasciomuscular release also combining with either cupping. So you can have the screw cupping, which can release the suction or increase the suction manually. So I can do this. It is not static cupping. It is biomechanical cupping. So that means Involvement of ITB with rectus femoris means the direction will be different. Involvement of ITB with the lateral biceps femoris means the direction will be different. Because it's the associated dysfunction which determines what direction you take the cup. And whether the patient is having difficulty with concentric contraction or eccentric contraction. Concentric contraction means we'll go from insertion to origin. Eccentric contraction means we'll come to origin to insertion. So this is something which may be easy to hear, but unless you see the course video, you can never do justice to the patient. I can guarantee that. So for people also who are more concerned about what is called as Itb syndrome, how long it can take to cure, okay, how long it can go. It is like a common cold. I am having throat and then cold I am having. How long will it take to go? If that cold is only upper respiratory tract infection, it will go faster. And that too at the early stage, if I do even salt water gargling, I will get cured. Because the virus in the throat will be removed by the salt water. But if I don't do that gargling, definitely the viral infection will go much inside, more chronic. Then my cough becomes productive with the sputum, and that sputum becomes more purulent. Okay, so it progresses like that. And I might develop even a bronchitis, or I can develop a pneumonia, and even opportunistically, maybe even COVID or Omicron. So you don't have any kind of an idea that common cold, how long it takes to go. You cannot answer. Because what is that stage in the common cold? What has caused that cold? That cause, if you treat properly, means it will go immediately. When you have an infection, even they do the sputum for culture. They see the organisms. They also see the antibiotic sensitivity. That means which antibiotic it responds. And then afterwards, when they give the right antibiotic, immediately the infection subsides. Same way, you should also see that what are the features which are abnormal in this patient. And for those features, what all treatment options I can give to match that pathomechanical dysfunction. If there is a motor control deficit, motor control training, without that, you are not going to do anything sensible. And then the next one, if it is about adhesions, layer to layer adhesions, okay, or muscle to muscle adhesions, okay, lateral, sideways. Definitely you have to use the IASTM. For those who have not seen IASTM, I'll try to show the tool now. Okay. I'm not able to find the tool. Okay. So I think IASTM has disappeared somewhere. Okay. So remember that instrument assisted soft tissue mobilization has different designs of tools. If I put this, go to Google, you can see here that IASTM. Immediately you will get this in the images, different type of tools. So all these are used for soft tissue mobilization. Here you can use the IASTM tools to separate muscle to muscle. Either superficial and deep also you can separate, but laterally you can separate better. So the tool can come in between. If there are 4 muscles, I can separate using the IASTM tool, the adhesions. Okay. So IASTM specifically, I always recommend for lateral adhesions. But whereas if the adhesion is there superficial and deep, I always prefer the cupping, so that the cup will remove it. The superficial layer will be separated from the deep layer. So think pathomechanically. Do not just apply the cup wherever the pain is there. Do not just do something with the IASTM tool around the pain area, whatever you can do. That is not techniques. What we need to have is, what is that muscle? Where is the direction of the fibers? In what action that muscle is insufficient, whether it is concentric, eccentric. That will determine the stroke, the direction of the IASTM tool itself. So understand and do not jump just into a technical thinking, like how to use IASTM. What is the dosage for cupping? Okay, that is technical questions. Because you are not going to use a cupping for 10 seconds, cupping for 10 strokes, cupping for 5 repetitions, like that. Okay, cupping is for the dysfunction. The dysfunction is restored, it is corrected, means you stop the cupping even after 1 repetition. Dysfunction is not responding, you have to modify the technique of cupping. You have to increase the suction of the cupping. So you have to modify for producing a response. When the response comes, then after that you can stop. So do not think of 10 seconds, 10 repetitions and 10 sets. Okay. That is not going to help at all. And it is not like every patient you will give the same treatments. Every patient, whoever comes with Itb syndrome, give the Itb stretch. What about Itb spasm? If a patient has spasm in tensor fasciae lata, you cannot stretch. So that time what you will do? Contraindicated for stretching. Everybody is thinking about Itb stretch. But that stretch is indicated only for tightness and adhesions. Tightness is shortening. The length itself became short. Adhesion means tightness is the superficial tissue is become short. That is tightness. Adhesion is got stuck with the lower tissue, so it is not moving. I am trying to move. It's not moving because of tightness is this. Movement is free, but it is tight. The muscle is tight. Next is its adhesion is there. Because of adhesion, it is not moving. So you just release the adhesion, automatically movement will come. You don't have to stretch it. The best example of such a demonstration is the upper trapezius. You do the lateral flexion, you will find there is a stretching sensation and you know the range of motion. You can look at yourself in the camera, in the screen. When you are doing the lateral flexion, you know the restriction and stretch. Come back. Go with your ulnar border and glide the fascia, keeping the neck in neutral. Just glide the fascia. Same like how I am gliding this. Okay. So you glide this. Again you bend. Now that stress sensation not there. And this is the thing that you should release first. Release the tissues. Do not stretch before release. And also sometimes the patient won't even allow you to palpate. If you do the release, patient will tell paining, 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 paining. Okay, during the release they will tell pain. That means there is spasm that is there. That's why they are not allowing a release. When spasm is there, what you are supposed to do is opposite muscle you activate, which is called as reciprocal inhibition. When you activate the opposite side muscle and then release, the pain won't be there. So the release becomes more easier because it is inhibited. The muscle is inhibited. The spasmodic muscle is inhibited because the antagonist is contracted. Resistance is given. So there are various techniques to ensure that patient in different spectrum of presentation, whatever the severe the symptoms, whatever worse the behavior of symptoms during the treatment, any of the technique, if the worsening of symptom is there, immediately we can go for relief of symptoms. That is what is AOMPT's clinical master classes are there for. They are not there for A to Z of protocol, but they are there for A to Z of clinical presentations. Whatever type of patient presentation you can treat. So that is the most important thing, how we approach a patient-centered paradigm. Okay, Redmi Note 8, I am not able to see who is Redmi Note 8. I want the person name only, not the device name. If device name is there, I will give certificate in the device name, not in the person's name. Okay, it's as simple as that. Who is Redmi Note 8? Who else is raising the hand? We have one participant raising the hand. Who it is? Bhumika. Yes, Dr. Bhumika. You can unmute?
Yes, sir.
Yeah.
Am I audible?
Yes, ma'am.
Sir, how leg length ITB is related to leg length discrepancy?
I will show you an image, for example. Follow it on the screen to the Google Images. Okay. Iliotibial band, frontal view. Okay. And we'll get an image. Yeah. Can you see this large image? Okay,
Yes,
the larger
sir.
image.
Yes, sir.
Yes, sir.
So here, for example, I am going to, I think it's not possible to draw on the screen when we are sharing through the laptop. Okay, I will move the cursor. This cursor, which is here, ASIS to ASIS. Okay, this is the horizontal line, the reference line. Okay,
Okay,
and
sir.
how do you measure the length from ASIS to the medial malleolus? So that is the true length which we measure for the total length. Okay.
Yes, sir.
So remember that if one pelvis is higher, one pelvis is lower, will it change the leg length?
Yes, sir.
So if tensor fasciae latae is tight, what it will do to the pelvis? It will pull the pelvis down.
Yes, sir.
Yes, sir.
Understood?
Yes, sir.
So at the origin means it will pull the pelvis down. When it pulls the pelvis down, it will create a lengthening. Okay, if tensor fasciae tightness. But if it is insertion that is pulling, the thigh will abduct.
Yes, sir.
Because the action of tensor fasciae lata is a flexion, abduction, and internal rotation. Because it's present anteriorly, it also creates an internal rotation moment on the hip. So it is abduction of the femur. Okay, anteriorly that is there. So flexion of the femur also, and the internal rotation of the femur. So remember that abduction will create shortening of the leg. So at the origin or insertion, which one it is tight? If it is tight at the origin, then it will create a lengthening. If it is tight at the insertion, it will create the shortening. IT band, how it can influence the lengthening or the shortening? IT band, when it pulls the greater trochanter, okay, greater trochanter down, it is pulled. So that means you have the greater trochanter, IT band is pulling it down. So that means it will cause lengthening. Okay, functional lengthening of the leg. What we are talking about is functional and biomechanical lengthening. But if you see that Gaudi's tubercle in the tibia, and usually the people have the genu valgum medially stretched, laterally compressed. Laterally, the iliotibial band is there, shortening, genu valgum. So this genu valgum will create the shortening. Also, you have the ITB, which has a paradoxical action. Okay. So the ITB has a paradoxical action. We were talking about the paradoxical action in terms of less than 20-degree extension means it will create extension. So that is the reason Genu recurvatum, hyperextended knee, ITB will be tight. So ITB tightness can cause an hyperextension of the knee in hypermobile individuals. Okay, like for example, in cerebral palsy, joint laxity is there. Because of that, hyperextension will come in the knee, and you will find that iliotibial band, it will be hard to palpate, very, very hard. Adductor tightness is spasticity, but iliotibial band tightness is tightness. That is musculoskeletal tightness, not the neurological. Okay. So remember that in every aspect, I am telling some example, I am telling 5% of what is actually the biomechanics for the leg length discrepancy. So ensure to understand, go deeper into the subject to see how ITB or tensor fascial lata can influence the leg length. Also remember that I was telling you about the rotation components, that internal rotation of the femur can be produced by tensor fascial lata. If the femur internally rotates, it will again create a genu valgum. That is the chain, the kinetic chain, lower extremity kinetic chain. Okay. So if the femur internally rotates, I keep the femur, I internally rotate, automatically it will go into a genu valgum. Okay. So remember that, and internal rotation will create a genu valgum. So this is automatically that happens. This is the mechanism in patellofemoral pain syndrome. Femur is excessively internally rotating. Why they are internally rotating? External rotators are weak, gluteus medius and minimus, and tensor fascial lata is tight because of the internal rotation. And ITB as a tendon, it is also getting pulled. What happens is ITB is attached to the patella laterally. So patella will be pulled laterally. So lateral tracking of patella, which can be due to the ITB dysfunction, which is secondary to internal rotation of the femur. The internal rotation of the femur happened only because weakness of the external rotators, or maybe because of femoral anteversion. You know that femur upper end, you can have this rotation of the neck of the femur with respect to the condyles. Okay. So there's an intercondylar line and there is a trochanter to the neck line. So there is a angle, anteversion from the horizontal to like this. Okay. So this anteversion is more, femur will try to internally rotate so that it can be inside the acetabulum. So these all skeletal causes, or it can be muscular imbalances, will lead to dysfunction of the TFL, and it can affect the patella or genu valgum or genu recurvatum. Okay. So remember that for everything we have a solution. If it is in patellofemoral pain syndrome, I will block the patella and I will release the ITB. And of course, before everything, I would have activated the gluteus medius and minimus using the pressure biofeedback. So remember that. But if it is anteversion, it is skeletal. I cannot do anything. Usually women, they have anteverted femur, because of which thigh is internally rotated. And because of which girls have the genu valgum. Knees are closer to each other. But if these girls are watching models walking on the ramp, catwalk, adduction, adduction, adduction. So what is happening? ITB tensile loading. Okay. Allow me and join in the screen. I will show you when you are seeing here catwalk model. Biomechanics pelvis. Show you. I want to move this away. Yes. And go down frontal plane normally not there. Okay. Catwalk model alone will keep such. Yes, absolutely right. See this model. Pardon me if any objectionable images is coming. I have to. Very tough. Okay, this girl. Okay. Right. So this is the typical catwalk. We are going to see the cat mechanics. What happens here is there is a hip adduction, right? All of you will agree that there's a hip adduction. What happened to the left ASIS is higher, whereas the right ASIS, you see, it is lower like this.
Yes.
There's a huge pelvic obliquity, which is done deliberately to make it attractive when they walk. So what happens is they drop the pelvis of this side intentionally. This side pelvis drops, and this hip abductors, the gluteus medius and minimus, goes for weakness, and the tensile or eccentric loading of the iliotibial band, and they develop the patellofemoral pain syndrome. And of course, high heels, gastrocnemius, overactivity will cause flexion moment in the knee or hyperextension of the knee. Both it can cause. Gastrocnemius also. Tightness means it will cause hyperextension of the knee. Same like how the cerebral palsy children, when they have gastrocnemius, spasticity and contracture, they will have hyperextended knee. So remember, even in the stroke patients also. Okay. So hyperextension of the knee, which may be common in women. And of course, flexion moment of the knee because of overactivity of gastrocnemius. Not tight, it's only overactive. So it will cause flexion moment of the knee, which will create a patellofemoral compression forces. So they develop patellofemoral arthritis. After, it's also part of patellofemoral pain syndrome. Chondromalacia patella is developmental. The cartilage is not fully formed. It is a more of a adolescent disorder which happens in the women. Okay, cartilage defect. Okay, the patellar cartilage, articular cartilage defect, which leads to symptoms behind the patella called as retropatellar pain or crepitus. So that is chondromalacia patella. There the problem is articular, only patella problem. But patellar cartilage always has the tendency, patella always has the tendency to move lateral. Because ASIS originates from the rectus femoris originates from the ASIS. ASIS is lateral to the patella. If when I am telling this, other people may be wondering, where is ASIS, where is patella? If you see here, if I put that for Q angle, you will realize that ASIS is lateral and patella is medial. So the pull of the patella is always in the lateral direction by the rectus femoris from the ASIS. So that is why patella will go lateral. Always that is the tendency. If the cartilage defect is there, it will go lateral easily. Moment it goes laterally easy, iliotibial band can migrate upper and upper. The stocking can go up because patella is laterally coming. When the stocking goes up, tensor fascial lata will get shortened. And further it will worsen the problems. It will lead to tensor fascial lata because it is tight, will lead to weakness of the gluteus medius and minimus. So that is from the knee chondromalacia patella, it leads to proximal. If it is chondromalacia patella. But if it is patellofemoral arthritis, problem can be in the hip after weakness of the glutei because of catwalk. Okay. And after that getting tensor fascial lata tightness, then lateral shift of the patella with the genu valgum or hyperextension. And the woman develops the patellofemoral symptoms. So remember that it can be both the ways. Proximal to distal in a catwalk, distal to proximal in a chondromalacia-petal. Okay. Right. Anup sir had asked a question of. Always remember, when you are actually trying to differentiate between spasm and tightness, palpation, spasm will not allow you to palpate. Tightness you can palpate. Okay. So you can palpate the muscle, it is tight. You will feel it is hard and tight. But spasm, you touch only, it will not be pressure, it will be pain. So that is spasm. And the next thing in tightness and spasm is you can stretch the tightness. Okay. You will find a stretch, then pain when it is tightness. When it is spasm, first when you stretch itself, paining. That is spasm. And the next thing about tightness and spasm differences. Elongating, afterwards, next elongation it will become free, next elongation more free. That is tightness. It eases with the stretching. Spasm means, next one will be limited. Next one, this much only will come. Next, this much also won't come. And next patient will be like this. Repeated stretching will worsen the spasm. Okay, don't ever try this on patients. And the next thing, if this is tightness, I activate the same muscle, asking him to push. Okay, so tightness, he pushes. Push, 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 push. After that, the range of motion will become better. That is post-isometric relaxation. If it is spasm, okay, this is spasm. I give push, pain, pain, pain. Clearly it will come, spasm. Do not mix these two. And that spasm, pain is there. You do opposite direction. Here spasm is there. You do opposite. After the opposite muscle contraction, spasm will lengthen. Automatically it will allow lengthening. So that is spasm. Reciprocal inhibition will relieve the spasm. Post-isometric relaxation will relieve the tightness. So same way IT band also, the components you can modify. If you want to focus on tensor fascia lata, you can give post-isometric relaxations because the tensor fascia lata can contract. But if you want to focus on the ITB, you will have to ensure rectus femoris or biceps where you are contracting together so that the ITB can be influenced either in a proximal direction or distal direction. Because ITB is like a sheet which just moves together. Either tensor fascia lata has to pull it from the top, anterior, or gluteus maximus has to pull it from posterior. Okay. So this is the two things in the proximal thing. Otherwise here rectus femoris and biceps femoris. So that also can influence the IT band distally. So ensure that your active techniques are targeted to the tensor fascia lata, where your palpation is between the trochanter and the iliac crest. Okay, so that is when it's the tensor fascia lata. That means between trochanter and the iliac crest. But if you are focusing on ITB and you are going to release it with the cupping, or you are going to release the rectus femoris with the ITB using IASTM, or biceps femoris with the ITB using IASTM, definitely it's a passive technique. So for passive one, you keep it passively positioned, either the ITB in a relaxed position or ITB in a taut position, taut, T-A-U-T. Okay. So it's an elongated position. So you can keep it relaxed position. Why ITB? When you are trying to mobilize under the ITB, you want to release the ITB away for cupping. That time you will keep it in the relaxed position, ITB shortened position. What is that? It is nothing but abduction, flexion, and internal rotation for tensor fasciae lata. But for ITB, flexion, abduction, external rotation. So flexion, abduction are same. For ITB means external rotation of the hip because it is much more posterior. And tensor fasciae lata means internal rotation of the hip. To keep the tensor fasciae lata relaxed. So even in a Ober's test, you can perform external rotation of the hip to elongate the tensor fasciae lata. You can perform internal rotation of the hip to elongate the iliotibial band. So that's why in Ober's test we perform the internal rotation of the hip. Okay. Next, not the same persons, other people who have to ask questions. Who all? Remember, even for strengthening, Dr. Chaitanya, come on screen. Yeah. Where is she here on the participants? Yes, ma'am.
Good evening, sir.
Yes, ma'am.
Sir, I have a patient, sir, she has a IT band tightness. She had IT band tightness, and whenever she walks, she complains of knee pain as well as the ankle pain on the same side and swelling of the ankle. Sir.
Okay.
So how is it related? Wanted to know, sir.
Can you repeat that? You have a patient who has?
So patient had IT band tightness, sir, and also knee pain. And whenever patient will go for a walk,
IT band tightness with the hip pain.
Knee pain, sir. Knee pain, sir.
Knee pain.
Yes,
Knee
sir.
pain is where?
And
Laterally
whenever,
there?
so, sir, anterior knee pain, sir.
Anterior knee pain. You are suspecting patellofemoral pain.
Yes, sir. Yes, sir. And whenever patient does walking, and she'll complain of swelling in the ankle and pain in the ankle to that night, sir. And she takes rest for 2 to 3 days, and again it goes off. So she that is inhibiting her to go to walk, sir.
She is more concerned about walking at swelling.
Swelling and walking, and she is unable to walk also, sir, to do the normal activities.
She is unable to walk because of
Swelling and pain in the ankle as well as in the knee, sir.
pain in the ankle also. It's a different problem. These are multiple problems. It's not just ITB syndrome. Okay. You should think in terms of why ankle swelling and ankle pain is there. There's a separate pathology there. Okay. So you are missing out on evaluating the ankle. And then the next thing, patellar symptoms and ITB, that should come maybe in stair climbing or squatting or sit to stand in order to tell that it is purely patellofemoral. Because you know, theater sign, knees in flexion, squatting. All this will bring the knee symptoms related to ITB if it is connected to the ITB. If it is in gentle walking, normal walking, and it is ankle symptoms are coming, ankle needs evaluation. Okay. Maybe 2-3 problems can be there in the same patient. Do not think that ITB is causing the swelling in the ankle. Okay. And don't think that ITB is causing pain in the ankle. Okay. There are rare situations where ITB can cause pain in the ankle, but that's a complex interplay. If you want to learn more about the interaction between hip, knee, ankle, you should take videos of Lexit, lower extremity kinetic chain integration techniques. That Lexit videos explain how femoral rotation, coxa vara valga, how it can actually influence the genu valgum varum, how it can cause muscle imbalances, whether it is adductor tightness or it is the tensor fascial lata tightness with the gluteus medius weakness, and maybe even a hamstring tightness, how it can cause a flexion moment in the knee, leading to anterior knee pain, patellofemoral pain. And the same way, lateral hamstrings like biceps, which I was highlighting on iliotibial band. Also remember that walking, if it brings bilateral ankle pain, bilateral ankle swelling, or is it only that the ankle on the iliotibial band dysfunctional side is swelling and ankle pain? Whether the ankle pain is unilateral or bilateral, swelling and ankle pain. If it is bilateral, it's a separate systemic problem. Patient may be having in terms of renal metabolism altered, they will have pedal edema. So any kind of metabolic challenge like walking or cycling or swimming, any kind of metabolic activity, they will have the leg swelling, ankle swelling. But if it is associated with pain, you should suspect more of autoimmune disorders, which might be polyarthralgia, polyarticular, multiple joint pain, like that. So both the ankle pain, okay, or even heel pain can come bilateral in ankylosing spondylitis. So that patient requires a rheumatological workup if bilateral symptoms of articular pain is there. Okay, just to identify it early, so that before they get into the deformities, they can start the medication so that we can manage them better and they can be functionally independent. If you ignore, don't do the rheumatological test, suddenly the ankle fixed deformity will come. It might be like plantar flexion inversion, or it can be dorsiflexion eversion, deformities of the ankle. So then it is very tough to actually treat, and surgical management also is very poor prognosis. So ensure that ankle has to be identified early, and see that if it comes on walking, like simple pathologies in the heel, plantar heel pain, comes on walking means early morning the pain will be more, the few steps when the heel touches the floor, and after a few steps the pain reduces, because plantar fasciitis also has a degenerative picture, early morning stiffness easing with the movements. So this osteoarthritis of the knee also, it has the same picture. Knee stiffness will be there when you are getting up in the morning, but it leads with the movements. Okay. So if it is the AOMPT clinical masterclass, what I would have done, I would have seen what is the problem in the ankle. First of all, evaluating the ankle is important. So whether it is the intra-articular problem or extra-articular problem, or is it a lymphatic or venous problem? Metabolic problem ruled out, systemic problem ruled out, connective tissue disorders ruled out. Then after that, I will go for joint restrictions in the ankle or subtalar joint or mid-tarsal joint, inferior tibial joint, mobility restrictions. So that is articular approach. Myofascial is to see for trigger points in the gastrocnemius. Tibial is posterior trigger points, and also go for flexor hallucis longus trigger points. These are all most commonly which comes in the leg. Okay, and it may be like compartment syndrome, because like shin splints, people will get swelling in the ankle because of the lactic acid accumulation, because delayed onset muscle soreness, or the medial tibial stress syndrome. Okay, the shin splints. So that is again eccentric overload plus metabolic. So all this has to be treated as a combination of multi-dimensional approach, like maybe a nutritional intervention, maybe aerobic training, maybe, for example, modifying, if it's an athlete, means the periodization, the training versus the practice schedules. What are the risk factors why the subject is getting again and again the shin splints? Okay, whether it is a vascular risk factor, whether it is a metabolic risk factor, whether it is improper technique, the coach will tell. Okay, the athlete is running in an improper technique. Because of that, having the shin splints. So that sports approach will go in a different dimension, including the psychological aspects of footwear, because these sports persons will have affinity to particular footwear. So even if the footwear is becoming very old, they'll be still wearing that. Because of that, they'll be having compartment syndrome and shin splints. That compartment syndrome causes the venous compression, so it will create a vascular stasis in the ankle. Pain, it can come because of venous stasis or because of arterial insufficiency also. Ischemia will cause pain. So it can be weight-bearing pain, it can be vascular pain, it can be like if the subject has nocturnal cramps, I will suspect it's a calcium deficiency and metabolic cramps. Okay. So that is again of the gastronomies. Neural associated with ankle pain and swelling. Most commonly, I will first check the tibial nerve, which is in the tarsal tunnel that is next to the medial malleolus. So tibial nerve tarsal tunnel syndrome, because sciatic carries the autonomic fibers to the leg for the lower. Are you able to see and hear me? Yeah, network issues. Dr. Darshana, where is Dr. Darshana? Hetu madam had to leave because of the routine emergencies. Where's Darshana? Can I see any participant on the screen? Darshana has unmuted the video, but I'm not able to see her. I'm able to see now Neil Shah, Shrishti, Dr. Darshana. I was putting her as co-host and nothing was happening. Dr. Bhumika.
Yeah, now we can hear you and see you, sir.
I think it's the SIM card I have. Okay, so I will now explain this model, which is just beside me, more colorful. I want you to have a look at the proximal area where this is the latissimus dorsi. Okay, and latissimus dorsi to the inferior angle of the scapula, and then it is going to the humerus to get attached. And this latissimus dorsi, lateral border of the thoracolumbar fascia, lateral and superior border of thoracolumbar fascia, is a diamond-shaped structure. Okay, lower border laterally, gluteus maximus, the red tapes which are coming, okay, very clearly, prominently, and you can see that the gluteus maximus is attached to the yellow, the fibrous expansion of the iliotibial band. So remember that iliotibial, so that is from the Asis to trochanter, then from trochanter, again it is going distally till the tibia. This, that is the iliotibial band from the yellow. Okay. And anteriorly, okay, this is the blue one, which is the tensor fasciae lata. Okay, so that is the anterior side of the hip. So remember that this is the black one, which is sartorius. If I remove the sartorius, this is the tensor fasciae lata. Tensor fasciae lata has attachment to the capsule of the hip joint also. Okay, so it's closely associated with the hip arthritis. Tensor fasciae lata can go for a spasm. Okay. Even hip intra-articular injuries like impingements, okay, impingements of hip. So sartorius I am fixing ASIS to the tibia. So this is sartorius, the black one. Okay, medially it goes. So posteriorly, ischial tuberosity, the three hamstrings. Okay, lateral biceps femoris, medially semimembranosus and tendinosus, semitendinosus. Okay. Here the black one, which is coming from the sacrum, and then it is coming to the trochanter, deeper to the gluteus maximus. Okay. Here, through the greater sciatic notch. Have an interconnection, very close overlap of piriformis with the maximus. Maximus connects the thoracolumbar fascia to the iliotibial band. Okay. So the implication is if the latissimus dorsi on the same side is tight, okay, latissimus dorsi is tight, it will pull the thoracolumbar fascia up. Okay, then what will happen? Gmax will become lengthened, taut. When it is lengthened, it cannot work properly. It can work eccentrically, but it cannot work concentric. Okay, because muscle is lengthened. So because of which Gmax weakness will come. Once the Gmax weakness comes, Gmax pulls the iliotibial band posterior. But tensor fascia lata pulls the iliotibial band anterior, the blue. So if the red is weak, the blue takes over and the tensor fascia lata comes anterior. If you want to see the direction of tensor fascia lata, it's similar to the pant pocket. How the pocket is there, side, okay, diagonally if the pant pocket is there. Through the pocket, we can lift the pant up. Okay. Some men do have the habit of putting hand in the pocket and then lifting the pant. Okay. Normal pants, not the jeans. Jeans, you cannot put the hand only inside. Okay. It's very tough. Especially in a rainy season, for example, we are going with a normal pant. And if the floor is very wet, we want to lift the pant. We can hold the pant from outside and lift it. But if our hands are inside the pant pocket, we can lift it with the pocket. Okay. That is the action of tensor fascia lata. It lifts the fascia lata. The fascia lata is like the pant of the lower limb. And it actually lifts up. Okay. So that is the blue one which is lifting up. Gluteus maximus also can lift it up posteriorly. Okay. So that is how tensor fascia lata tightness comes in the same side where the latissimus dorsi tightness is. When you are asking subject to stretch the tensor fascia lata, we tell the patient to keep the legs crossed and then bend to the opposite side with the arm elevation. Why are we telling the subject to keep the arm elevated and then bend to the opposite side? Is because latissimus dorsi of same side also should be stretched together. So that is the problem here. The same way like a patient who is using a cane, walking stick, the side of the upper limb where they are using the cane, the latissimus dorsi will become overactive. And the same side, the tensor fascia lata, shortening will come, predisposition. Okay. So that tensor fascia lata will not become tight. If gluteus medius minimus are normal, definitely tensor fascia lata will never become overactive and tight. So, right, so the anterior and the posterior. And also I want you to observe another relationship, which is the iliotibial band is laterally there. Okay. And this lateral Gmax tensor fascia lata, that much is not lateral. Iliotibial band is lateral. And then you see here ribs to the iliac crest. There is a purple tape and there is a white tape. This white tape is the internal oblique, which creates the rotation of the trunk to the same side. The purple tape is the external oblique, which creates the rotation of the trunk to the opposite side. External oblique. Both the oblique. So that means ITB, tensor fascia lata, external and internal obliques, intercostal muscles, and even the sternocleidomastoid, the anterior fibers of sternocleidomastoid. All of them are lateral myofascial kinetic chain. So if you are, what is the implication of kinetic chain? It's a different course. Unfortunately or fortunately, remember one thing, every word what I speak, there's a separate course in AOMPT. That's the depth of education that the academy is providing. That's the reason why we are the world's largest manual therapy academy. and the world's most top-rated academy in Facebook for the manual therapy courses. And we provide the maximum online courses provided by any academy in the world. And of course, maximum free webinars which we have taken. And today is 211th free webinar, which we are taking in the past 2 years. Only the past 2 years. So AOMPT is known for establishing newer benchmarks where we compete with ourselves. We keep our own targets. I was putting that as a caption. Challenge yourself. Keep on challenging yourself. For an interactive webinar, why I should put these tips? But this makes me to go beyond what I usually do. I don't compromise. Okay. So ensure that when you do the work, automatically work also starts doing wonders for you. When you work for excellence, when you dedicate yourself for excellence, when you invest for excellence, excellence start working for you. You will do little, but the outcome will be extraordinary, especially in an exam. And I want to hear from Dr. Darshana because she has given the MPT exam. Yes, Darshana.
Yes, sir. Yes, yes. I think each and every word what you said now is like so true, because I have been with AOMPT for last 2 years, and I think after giving this exam, yes, I feel that it has made a huge difference. I'm waiting for my practicals though, which is in the coming week. But I'm sure whatever knowledge I've gained from you from the last 2 years, it has given me that confidence to give the exam. It's like, yeah, I mean, definitely I need to go back to the books also, but that practical knowledge and especially all the muscles, nerves, whatever you show, on the model like this, which you have shown today, the IT band, and all the muscles, like we have learned so many courses, we've done so many courses, and that's the way you teach. We know, like, this is the way, with so much of perfection you teach us. So that makes us learn in a much better way than we could just learn from the books. And that makes a difference there. We can, recollect anytime. We can actually go back to that course and, okay, this is what we have seen. That makes it easier to understand and to recollect. So it's definitely a great way of learning from AOMPT. And thank you so much, sir, for that. And today's course was also one of the extraordinary ones, as usual. We have learned IT band, but as I always tell you that every time in a session, we learn something new. So definitely today was also something different from whatever we've learned. And of course, for all the participants, whatever sir has mentioned today, all the techniques, it's not just hearing today and then applying the techniques as sir was mentioning, but it is like learning those techniques in depth and having a clinical reasoning for applying those techniques is something very important, which I think only you will understand if you take the videos, enroll in the courses, learn better, and then apply the techniques judiciously. It's not just learning the technique and applying it wherever. It's like, okay, I've learned my MFR, okay, I will just use MFR. It's not that. You should know the reasoning. Okay, why I'm doing MFR, why I'm doing muscle energy techniques, or why I'm doing taping for that matter. So that is what we have learned from you from last 2 years, that clinical reasoning is very important. You should be able to understand what is muscle tightness, what is spasm, the difference between very basic things, which we actually forget. Like, we see a patient and then we are like, okay, pain hai, chalo, give this. But if we understand this, which we have understood, at least to some extent in the last 2 years, that, okay, when we have a patient with pain, we know where to differentiate what, like whether it's spasm, okay, then what to give. If it is tightness, then what to do. And I'm sure I can tell this with so much of confidence today because it has made a difference in the treatments what I give to the patients. So I think it's very much advisable for everyone to get back to AOMPT videos, to enroll in such courses and learn better and apply the techniques better. And thank you so much, sir. Thank you, everyone.
For example, here, even you can see the tensor fascial lata here, okay, anteriorly there. So it's clearly visible, the blue tape, okay, anteriorly in the hip. So I can put the Mulligan belt, okay, in the thigh and create a distraction laterally. And tensor fascial lata is attached to the capsule also, hip joint capsule. So I can lengthen the muscle, at the same time I can distract the joint also. And tensor fascial lata tightness will create a joint compression, hip joint compression, leading to hip OA. And hip OA, internal rotation is the one which is painful. Passively also, crepitus, all that. So remember, everything is related to the one way or the other. So when I am giving a myofascial technique, at the same time I can do a articular technique. So I can put the belt around the thigh, and this belt will be giving the lateral distraction force. Okay. And with the lateral distraction force, there is another leg here. Okay. So this leg is lateral distraction. Okay. This Mulligan belt. With that, I will give the release of the tensor fascial lata, which is either with the cup or ISTM. So with the articular technique of MWM, which is distraction, mobilization with movement, I will give the myofascial technique together, because both are pathomechanically interlinked. So I can release them together. And also, if you see that the lateral part, lateral femoral cutaneous nerve, that's what Ritu Ma'am had mentioned, that lateral femoral nerve is nothing, no problem. Okay, like that. So in the slump test position or SLR position, when you do the adduction, it is the lateral femoral cutaneous nerve, which usually exits from the inguinal ligament. Where is the inguinal ligament? If I have to keep from the Asis to the pubis symphysis, that is the inguinal ligament. And this lateral femoral cutaneous nerve exits like that, here, just below the Asis, like my index finger. So people who are obese, abdominal content can press on the lateral femoral cutaneous nerve. Or dysfunction of pubis symphysis, inguinal ligament tenderness, because of that abnormal position of the ilium. So that can compress on the lateral femoral cutaneous nerve, causing numbness along the tensor fascial lata and the Itb, the lateral aspect of the thigh. That numbness will be reproduced by adduction force of the hip, and that adduction with neck flexion. Neck flexion will aggravate the thigh numbness. Neck extension will relieve the thigh numbness. So that is neural component of differentiation from the neck. And again, neural treatments are there according to Shacklock sliders techniques, which we can use it for lateral femoral cutaneous nerve, where the differential diagnosis is neuralgia paresthetic. Yeah. Pancreatitis. Other differential diagnosis is OA hip. Other differential is between the tensor fascial lata and the Itb itself. And then in Itb itself, different level of injuries, different types of injuries are differential diagnosis. So whether it is proximal or it is distal, whether it is a strain or a sprain, partial, rupture, tendinitis, tendinosis, IT band friction syndrome, which is distally there. Okay, so a lot of IT band tendinitis or runner's knee, which comes in sports. So every person, every one of us will have IT band tightness. We don't require a treatment. We need to see that whether the tightness is the cause for the symptoms. It may be a pelvic symptom. It can be a low back pain. It can be a hip pain. It can be a knee pain. The Itb can affect anywhere. And as tensor fascial lata is related to latissimus dorsi, Impingement syndrome also, it can be related to the lower limb. So always remember that shoulder impingement syndrome in athletes, if they have same side IT band tightness, you need to recheck whether treating that IT band, whether the shoulder symptoms are getting better. I'm having an impingement throwing time. You treat my right side ITB. After that, I am feeling my shoulder is free. Understood? It clearly tells that from the lower limb and the torso and upper limb through the latissimus dorsi, thoracolumbar fascia. So all this has to be explored because every patient has their own lifestyle, dominant side and non-dominant side. Lower limb also. Dominant side, tensor fascial tightness can come. Non-dominant side, iliotibial band adhesion will come. Among these two only I am telling, which are likely. Because non-dominant side is weight-bearing side, which always goes for adduction of the hip. So the iliotibial band will go for taut and then adhesion, non-dominant side. Whereas the kicking side, football kicking side, that is dominant leg. So that is flexion. Flexion will activate the tensor fascial lata. So that is why tensor fascial lata tightness is there in the kicking leg, the dominant leg, whereas IT band adhesion is there in the non-dominant leg. So both may be having similar finding of patellofemoral pain syndrome, but the cause in the non-dominant side is iliotibial band adhesions, whereas the cause of the patellofemoral pain syndrome in the dominant side is tensor fascial lata tightness. So make sure that we have to differentiate, explore more into the biomechanics, because there is no better profession than physical therapists to proclaim ourselves as movement scientists. Do not learn structural treatments. Apply the treatments biomechanically and apply the treatments problem-oriented manner. Okay, what is the problem? Patient is having difficulty with squatting. I will treat in squatting position. A patient has a problem in stair climbing. I will keep the patient in stair climbing position and I will release the ITB. If it's the runner's knee, subject is running and getting IT band symptoms, athlete, endless probabilities. Do not narrow down your thinking and focus on techniques. Expand your thinking to understand the pathomechanics. If you know the pathomechanics, you are treating the patient, then you are a clinician. If you don't know the pathomechanics, you know only the treatment parameters, you are applying the techniques, you are a technician. So try to see that it does not matter whether you are diploma holder or you are PhD holder. You differentiate a technician by diploma holder, clinician by MPT. No. Whoever is thinking technique centered is technician. Whoever is thinking patient centered is clinician. So I appreciate all your participation. Anybody wants to ask questions in the end of the session here? Someone who has not got opportunity to ask on the screen. Don't expect us to read the questions in the WhatsApp group and all. I ask the questions because your thinking should start that time. In the screen you are supposed to ask. That is only is important and considered as valid. Even putting it in the chat, it's not the way that you are supposed to ask a question. You're supposed to ask direct on the screen. So always remember and ensure that AOMPT is always there to hold free webinars. These free webinars are for just opening your eyes and knowing that there is some light. Okay. Actual thing is you have to walk in that road and you have to pursue the direction of the light and enter into the glory of the knowledge. So that comes with the courses which are nowhere in comparison. These free webinars are like not even 1% of what will be there in a clinical masterclass. If I am taking on Itb syndrome for 2 hours manual therapy demonstration, that 2 hours of demonstration is equivalent to 1 full day of a direct workshop. 8 hours of demonstration, whatever, 8 hours workshop, 6 hours you will have, 1 hour lunch, half an hour refreshments. So 6 hours only workshop will be there. That 6 hours of content of demonstration is demonstrated in the 2 hours. And you are getting this video as a lifetime access. So do not miss the clinical masterclasses. We have 10 clinical masterclasses of the AOMPT, which are included as certified musculoskeletal practitioner. Other than that, also we have a free masterclass for almost every condition. You want for cervical radiculopathy, you want for cervicogenic headache, or you want for vertigo. Every condition it is there. So make sure that on your interested topic, you can always take the video from the AOMPT, learn and become better, use it on the patient, come back and you can discuss in the group or in the interactive webinars. So always remember. So I take this opportunity to wish all of you the best of luck and ensure that we can better manage these patients only if we know better. So faster recovery is possible only if we treat the exact cause, for which the cause of interaction we have to know. Because all the structures are working together in the body. You don't think that gluteus maximus weakness, so tensor fasciae lata got tight. No, there are a lot of things happen in between. So that is the body, human body. So understand and speak to the human body when you are treating the patient. Your hands should speak to the body when you are palpating. And of course, we are always there to take you in the path of excellence. Yes.
Thank you so much, sir.
Yes, Ritu ma'am, final closing words.
Yes, sir. Thank you so much, sir. It was really a very nice and interactive session where from the questions, for my question or the others' question, we have learned so many new things again about the IT band and the relation with the tensor fasciae lata. That is also a very unique thing which we have learned because we are just focusing on the IT band only. But now I can understand that IT band itself is a very international model. So he influenced hip also, knee also, and till the foot he go for the influence. And
actually ITB means Indo-Tibetan border. Okay. That ITBP, Indo-Tibetan Border Police. Okay, ITBP. Okay. Yeah.
So it was, I think, because the patient having the knee problem or the hip problem after the surgery, also replacement, then the IT band plays a very major role in this because in the knee problem, so it's directly patients suffer with the tightness or there is a pain, the myofascial tightness and the trigger point in the IT band, which we have to release with the actively, as we learned from AMPT that as a fasciomuscular release technique where we can contract the muscle as well as we can release. So this is all the new things which we are learning from AMPT, where we added so many new things according to the patient-centered approach so that patient can get benefit. So it's I think today's topic was really mind-opening session because I think every physiotherapist see the patient of IT band in their day-to-day practice, but we mismatch the symptoms and we mismatch the treatment. We are not going in a right way. We just match with the hip. We treat hip, we treat knee, but the bridge between hip and knee, we miss the IT band. So it is very important to learn.
Actually, hip, all the muscles are like that only. Rectus femoris crosses the hip and knee.
Yes, sir.
Sartorius crosses hip and knee. Gracilis crosses hip and knee, adductors.
Yes, sir.
And you have ITB crossing hip and knee.
Yes, sir.
Hamstrings, all of them from the ischial tuberosity to the below the knee. So remember that all these muscles are two joint muscles. So that is the major picture, that you cannot evaluate the knee without clearing the hip.
Exactly. Yes, sir. So I think very nicely you have answered all the queries, so that I think everyone has received their proper answer, and they can now match their answer with their patient symptoms, and they can learn more, because in our neuromanual therapy course you have explained completely about the IT band with the neuralgia paresthetica symptoms. You have added how we can differentiate between the IT band and the tensor fascial lata symptoms, how we can differentiate, because it's a long liver muscle and the short liver muscle. According to that, we can check with the where it the influence of knee extension and flexion is not. Yes, sir.
Also, if you see concentric function,
Yes.
tensor fascial lata. Eccentric, the tendon only gets loaded in any
Right.
muscle. Here the tendon is long, iliotibial band. So eccentric is iliotibial band.
Right.
So closed kinematic chain, when I'm walking, especially like catwalk I was showing,
Yes, sir.
the load will come on iliotibial band there. Because
Yes, sir.
adduction force, eccentric,
Yes, sir.
closed kinematic. Weight, football, which I was telling, open kinematic, that is tensor fascial lata. Concentric.
Yes. So I think these things are very mandatory to know about these small things, where which muscle is playing a role, either in a open kinematics or the closed kinematic, which muscle we are going to treat. After that, we can easily manage that the dysfunction or the symptoms of the patient, we can correlate, and then we can give our proper treatment. So it was very nice session. Always AMPT session rocks. And today's session was also very nicely explained by you. And our Darshana ma'am is also back. So we are learning together again. It's a happy moment for me. My classmate is back.
Same
So
here.
thank you so much, sir. And thank you, ma'am. And thank you all the
Thank
participants,
you.
because all of them, all the participants made this session very unique and informative. Because of their questions, we were able to learn more and more from you, because AMPT is itself an ocean. Whenever who take the plunge and that, so that they can get their answer. So the same thing is that when the questions come one by one and sir gives the answer, we learn more and more new points according to sir answer. So thank you very much to everyone. Please join AMPT, take the best courses. You can also upgrade your skill. You can learn, and we can learn together with all the questions and answers from the session. Thank you so much. Thank you, everyone. Yes, sir.
Yeah, Dr. Anup sir.
Good evening, sir.
Are you on the screen? Yes, sir.
Sir, good evening.
Tell me, sir. Question.
Sir, can we,
question? Which question yours was?
sir, I was just talking about the iliotibial band. Actually, in TKR, it gets tightened and restricts the flexion moment. And sir, one more question, sir. Can we treat any dysfunction by applying the techniques on the fascia to strengthen the muscles?
For example, biceps I am strengthening. Okay.
Yes, sir.
So I am doing bicep strengthening like this. Okay.
Right, sir.
Like this I am doing. If I am keeping my palm and keeping the fascia in a proximally glided position, and then I ask the subject to work out, he will be able to lift more weight in that same biceps.
Okay.
You can see now also, yourself also, in your arm. Okay. When you are lifting a weight, you keep a weight, you take it. You see the load on the muscle, how easily you can lift. Even simple, without weight also.
Right, sir.
How you can do. At the same time, keep it firm, glide the fascia proximally, and then do. You will feel like you can do it 200 times compared to the initial 20 times where you are getting tired. Because you have glided the fascia in the direction of the concentric contraction.
Right, sir.
If I want to strengthen biceps eccentric, okay, eccentric. So I am strengthening, lowering, lowering, lowering. Okay. and that lowering I'm doing slowly, or I give the weight, after that lowering, take the weight, give the weight, then lowering, take the weight, give the weight, then lowering. So that also eccentric only. So when I'm doing this eccentric, the fascia has to be glided distally. And then I do an eccentric training. So it's easy for me to do the eccentric training because fascia is glided in the direction of contraction. Definitely the muscle contraction will be much better.
Much better.
If the facial glide is restricted, definitely it is like fascia is not free. Okay. And the muscle is under that. Okay. So muscle is like this. Fascia is here. Fascia not free. Can the muscle work?
No.
If the fascia is free, muscle will work.
Muscle will work.
Okay. Because muscle is elastic, fascia is not elastic.
Right.
So you have to mobilize the fascia, then muscle becomes elastic. So even after cupping, patient can have better activation of muscles because you have separated the fascia, the other sense. But in AYMPT, we give strengthening with the cupping. We give balance training with the cupping. Okay.
Right, sir.
So we do everything that is functional. That is what is we are envisioning rather than a technique dependent practice, and ensure that every type of patient we can treat. Okay. Not like only those who are suitable for the cupping alone will treat. If they are not suitable also, still we can treat. So that should be the goal of a clinician.
Excuse me, sir. Sir, like in OA knee.
Wait. Any other participants? Neil Shah. What Neil Shah? Ask in English, no Hindi. Hindi is only in WhatsApp. Yes.
How are you, sir?
Yes, Dr. Neil.
Yes, sir. No question, sir.
He's become like the Miss India who won the Miss Universe. Suddenly on the stage and you don't know what to talk. What, sir? I've always seen that. Dr. Shishti has any question? Able to unmute? First you unmute. Yeah. No. Is it audible, Dr. Darshana?
No, sir.
No, sir, he's not audible.
You better talk directly. Don't use the earphone. Yeah.
Sir, am I audible now?
Yeah, audible.
Sir, is there any numbness? Because some patients of Itb syndrome, I have a patient, lady patient, she complains of numbness. She was having Itb syndrome.
Numbness.
Is there any neural tissue involved?
Neural tissue. Are you asking, is there probability of a numbness in IT band dysfunction? Neural tissue involvement. That's what we were talking almost 15 minutes with lateral femoral cutaneous nerve. Neuralgia paresthetica. I was showing all this beside the inguinal ligament. The nerve is coming. Adduction with the neck flexion extension. SLR with adduction or slump test with adduction force in the hip. All that is, and also even Dr. Ritu ma'am, what she explained for neuralgia paresthetica. The same way like lateral femoral cutaneous nerve along the ITB. Now your voice is not audible. I think it's got muted. Okay. Bhumika? Yes.
Yes, sir.
You have any final clarifications you want to ask?
Sir, I just want to ask for gluteus medius and minimus, how we use pressure biofeedback? Just the
No
position.
shortcuts to success.
No,
Okay?
sir, just the position.
Nothing. Nothing means nothing. I will not tell you because you will not take the course. And you will, incomplete knowledge, you will try to do something. Okay? And any kind of substitution, immediately IT band will become a tensor fascial latae will go into spasm. So always remember how to reach that position itself. There is a positional release, reciprocal inhibition, all this we use. And then we reach the position. Then we give the motor control retraining. It's not and then lifting the leg. Okay, gluteus medius minimus. That is the anti-gravity 3+. But when it is 1 also, how to ensure that motor control activation is happening in gluteus medius? That is the thing which we need to technically learn step by step. And it is like, for example, even with the breathing also, everything has to be incorporated together. It's not just the position. Hip is kept abducted, externally rotated. Okay, what you are going to do with this? Okay, see, abduction, external rotation is the action of these muscles. So you have to keep abducted and externally rotated only. You can't lengthen the muscle and expect it to contract whenever you are facilitating a muscle. Quick stretch in extremity, dorsiflexors, common peroneal nerve injury, foot drop. You will do a quick stretch because it is peripheral muscle. Here in the hip, how can you do the quick stretch? Impossible. Okay. So you will keep it in the shorter position, inner range contraction first you will facilitate. So basically we should be aware of what are the actions of these muscles in different hip positions. Hip is neutral means what is the position action. Hip is flexed means what is the action. Hip is extended means what is the action. Okay, this is sagittal plane. In that only rotations of these muscles are varying, like piriformis. The rotation changes with the flexion degrees. Same way, abduction also will change the action of flexors, which are there. Like you want a iliopsoas, which can also produce an abduction, but external rotation. Tensor fascial latae, abduction and internal rotation. All these are very easy to tell. This is same as what is there in the anatomy textbooks. But what's important is how you observe on the patient, how you do it in closed kinematic chain when the patient is standing. Still that same incorporation of this mechanics. So that is the course under master classes. Understood? And ensure that we can guarantee that no patient will have worsening of symptoms. That is the point there, point blank. You don't need to keep cold pack. You don't need to keep any tense. Without that, manually itself, right from first day, severe pain with spasm, bring the patient out and get into functional training. So such a foolproof protocol. So make sure that you learn this, but as a clinician, ensure that always apply it together with electrical modalities, mainly because patients will come for 1 week if you are using the electrical modalities. Okay. If you are not giving electrical modalities, patients will stop coming after 2 days. They'll think that manual therapy exercise only, so they won't come. Because our Indian public awareness, their psychology is totally different. You keep an ultrasound you are giving and you tell 2 weeks ultrasound package. For that ultrasound, they will be coming 2 weeks. Okay. So the patient follow-up will be maintained. So just for that, use the ultrasound. But don't think ultrasound is producing any effect. Okay. It does not have any effect at all. Right. So ensure scientifically you apply that and also ensure that it is a combination of techniques which we are using simultaneously that will be beneficial for the patient, any patient. And never treat even the right side ITB tendinitis versus left side ITB tendinitis as same. Okay. The patient may be bilateral ITB tendinitis, but it is not right and left are same because one is dominant leg, other is non-dominant leg. Dominant leg, it will be tensor fascial latae dysfunction common primary, whereas in the non-dominant iliotibial band dysfunctions primary are common. So this is what I wanted to highlight, and ensure that you treat the difference between every patient. Do not treat all the patients similarly. Treat them equally. Rich patient or poor patient, treat them equally, but don't treat them similarly. Okay. So you have to ensure that evaluate the difference. So that is the skill of a clinician, right? So we close the session live on Facebook. First, I'll stop the live streaming. Wish you all the best of luck. Of course,
Thank you, sir.
in the Navaratri in North India, plus also, of course, the Ramadan festivities. So make sure that the COVID restrictions are lifted off. Okay. Lot of changes are happening. Let's see 2023 how it is. Make sure that you can do better therapy for your patients by becoming better. Empowering yourself with knowledge is the only investment for excellence. And when you have excellence beside you, money and success, they beg and come after you. So ensure that which is highest priority and try to genuinely upgrade yourself from sincere teachers who share knowledge in free webinar also, not like they share only in direct workshops, no online video. Okay, these kind of instructors and all don't go and attend the direct courses, because you can be very sure that they are not going to teach you anything at all in the direct course, because they are not teachers, they are workshop resource person. Okay, so remember the difference and try to see how you can genuinely and truthfully you can become better. Okay, so see you. Good luck. Dr. Darshana giving a practical exam. Preeti
Thank you,
ma'am,
sir.
daily it is a practical exam only for her. And Anup sir, Dr. Neil from Surat, Dr. Bhumika. Okay. Others who are off the screen, Shrishti, Amir, Gabu. What is Gabu's? Dr. Chaitanya ma'am, Dr. Muzamil, Dr. Manigandan, Renuka, and Ashin Shana. Okay. Right.
Yes, sir.
See you. Bye bye.
Thank you, sir.
Stop the stream.